durante 1 hora, me han dicho, o sea que el que quiera puede tomarlo.
So as the speakers come up, can I ask a question in the audience? So most of the people in the audience are urologists, I presume. Do you ask for a biopsy on a PARADS 3 lesion on MR from your own practical experience? So you get an MR, there's no PARADS 4, PARADS 5. Do you send the patient for a biopsy or not? Or do you actually take PSA velocity, PSA density into consideration and then decide to send the patient for a biopsy or not? So you send for a biopsy for all PARADS 3? That's good to know. I think the practice is different. In our hospitals, mostly PARADS 3 will not come back for a biopsy. And if I am reporting a PARADS 3 lesion, I know that my urologist will not until and unless I have a strong suspicion. So I would put something in the report. Although this is a PARADS 3 lesion, I would probably say this is a Lycott 4, meaning which that this, even though if I go by the standard definition of what a PARADS 3 is, especially in the transition zone, I have to call it a PARADS 3, but I would actually convey in my report that I still worry that there could be a cancer, and those patients will definitely come back for a cancer, for a biopsy in our personal practice. Any questions in the audience? So maybe I have a few questions. So when we talked about the discrepancy in the role of MRI and double reading, so I guess this was after a few years, the level of experience was very good, and you found that the discrepancy rates were extremely low, like less than 2%. Yeah. And I think that's what's been published in the literature as well. You want to have double reads as one starts reading prostate MRs. I would say it should almost be mandatory in every practice that the first 100 or 200 MRs for a new staff, not resident, but when you come on staff, you have a double read. You have some experience who double reads with you. I think that's extremely important. And I think it's also very important for all of us in the radiology group to have follow-up of the biopsies, to audit ourselves. How many of my PARADS 4 and PARADS 5s actually come back? Is it in line with what is published in the literature, or am I actually off mark? And that's why there are many workshops, prostate MR workshops that are held in different parts of Europe and America. So for the study where you compared MRI to microultrasound, there were many lesions that were picked up on microultrasound, and I have some experience with microultrasound. We were part of the RCT across the 5 sites in North America initially. Were the size of the lesions small? Did you retrospectively go back and see, was it because they were not showing any restricted diffusion, that's why we were not calling them a 4 or 5, or was it actually not visible at all on MR?
That's a very good question. Actually, I have to say we did not look to these lesions retrospectively, and I think also one of the reasons why the performance of multi-parametric MRI, at least in our ends, is not that good is for the reasons that you were saying. So there are lots of patients, at least in Italy, that come to our hospital, referred by a third party and come with an external MRI. It's not, unfortunately, a routine practice for our radiologist to review all these images, and so most of the time we have to stick to what the external radiologist said. And my personal practice, I have, I think, a kind of good practice in now countering all the lesions by myself and everything, and sometimes you really get in troubles because it is not that easy to find a correspondence, and that's the reason I think why in our experience the performance of multiparametric MRI was not actually that high, was not probably that comparable to that of most of the studies on multiparametric MRI that have been published so far. So.
Yeah, I must add that I was part of a small study done in North America. Just 9 patients who were on active surveillance had an MR and then went on to have micro-ultrasound biopsy. There were, I think, 4 or 5 lesions which were picked up on MR and were also prospectively picked up on micro-ultrasound. So micro-ultrasound picked up all those lesions. But there were at least 4 lesions which we saw on micro-ultrasound. They were all very small lesions, though. They were all like 5-6 millimeters at the most, which we could not retrospectively see on MR as well. So we went back.
So that could be a reason.
Came back.
Yeah.
So probably small lesions, not showing enough restriction, and picked up by micro-ultrasound.
That could be a reason, yeah.
So Dr. Solomon, sorry. Yes, absolutely.
So my question is for Georgi, for all of you. I mean, when the whole story about insignificant prostate cancer started, it was like the problem was not treat or not to treat. The problem is, for me, avoid finding these cancers, right? And in this way, we are in the MRI era. And I answer to the question of the chairman saying, well, I biopsy almost PIRAS 3, almost all of them. But the problem is not biopsy PIRAS 3 or not. The problem is not finding the PIRAS 3s. And the problem is that we are getting to the situation where we need to select those patients who are suitable for MRI. Because this story is destroying clinical practice, at least in my place, where young resident, first year, elevated PSA MRI, without actually even thinking whether the guy is 85, 42, big prostate, bulk prostate. It's just radiology. And this is killing urology. So what is actually your position in say, listen, maybe instead of giving patients, maybe we can just use the brains and avoid a lot of MRIs?
Yeah, I agree that, perhaps in patients who are biopsy naive, you question the role of MR at this stage, even though there was a statement which came out very recently. But MR may have a role and will have a role in patients who've already had a biopsy. There's a clinical disparity, and there might be many of these patients who may have interior tumors. So, yes.
Maybe I have a comment to Alberto, because I think you're absolutely right that we do not use our brains, and if we change the guidelines to MRI first, it will be a reflection of everyone. Oh, the PSA is getting up. Even the general doctor will send him to the radiologist, and we are doing not good, because the main problem is education, and it's not. The time is not right for widespread of MR first, and second, what Alberto said, we will lose our brain for clinical decision making.
That's a good point. So, Dr. Solomon, coming to your study, so for me as a radiologist, I struggle most in calling a lesion in the transition zone. And if you look across the board, most of the radiologists call, so for peripheral zone, the PIRADS 2 version has a relative objective criteria. It's T2 dark, it's a mass-like lesion, it does not restrict too much, mild restriction, right? And so it's almost a subjective criteria, objective criteria. Well, if you look at the transition zone, it's a very subjective, like, obscured margins to me may not be obscure margins to 10 other radiologists. But most of your lesions, I presume, were in the peripheral zone, because Primus, as of now, is only for lesions in the peripheral zone.
Absolutely, and I think ultrasound won't help in that way. I think that's the main problem of ultrasound, the transitional zone and the ventral zone, which is not due to the depth of the ultrasound. The technique itself, that's the limitation. So anyhow, I think the combination of both methods, MR and micro-ultrasound, will improve it. It's a question of time, and if we want to do that, and of course of money, that's absolutely, without doubt.
perhaps that may be the answer in the future. If you have a Paris 3 lesion in the peripheral zone, look on micro ultrasound and decide if you want to put a needle in it or not.
Regarding the PIRATS classification and the peripheral and the transitional, is to note that it's different in PIRATS 1, 2, 4, and 5, but PIRATS 3 in transitional and peripheral zone is the same. So PIRATS 3 is so indeterminate that it's not even different the classification in the PIRATS version 2 in peripheral and transitional zone is the same. So there's no difference.
Yeah, I think if you look at the PIRATS version, clearly, it says PIRATS 3 would be obscured margins, while it doesn't talk so much about diffusion-weighted imaging. But I think that's where the version 2.1 is coming out now, where there'll probably be some more weightage on diffusion-weighted imaging for lesions in the transition zone as well. But I totally agree that it can be a problem when we start calling too many PIRATS 3 lesions on MR, and the positive rates are somewhere between, I would say, 10 to 18% across the board at most of the academic centers. If there are no more questions, we'll close the session. Thank you, everyone. Thank you.
Nadie dijo que esto iba a ser fácil. Nadie dijo que esto era fácil, ni que vamos a responder a la pregunta de ¿hay cáncer o no? A la primera, y que nadie salga desilusionado de esta sesión.